Thank you so much for the invitation and for the challenge of arguing in favor of a combination that has not been tested yet and there is no data for. But it's a good challenge and a very important challenge, so I really appreciate it. These are my disclosures. So what are the goals of induction therapy? It's really to eliminate or reduce all the comorbidities associated with the disease, to achieve a profound and robust cytoreduction with good disease control, and has to be so effective that it has to be a continuous form of control. It has hopefully to affect positively overall survival. It has to be well tolerated and maintain a good quality of life. And I'm sure that by reducing the comorbidities of disease, the quality of life most of the times will improve and will allow, if not facilitate, at least allow stem cell collection to be able to be used as consolidation therapy in the context of stem cell transplant for those patients who could tolerate it. So those are the main objectives of frontline treatment or an induction therapy. And you all are aware of the most commonly used, and I made a list here going from the left to the right. You can see the CR rate, the NCR rate, and the VGPR, which are indicators of robustness of the response, and you can see the different regimens. CyBorD gives a CR rate of 39%. The BIRD, which is what we do in Weill Cornell, is 38.9%. And VRD, which Dr. Richardson will talk about following my presentation, gives anything between 26 to 30%. The most effective ones, and they have not been compared head-to-head, but in these two different trials are the Carfil, lenalidomide, and dexamethasone. As you can see the data here, one data from Dr. Landgren and Dr. Korde, and the other data from Dr. Jakubowiak. So if the goal is to achieve a maximum response, that's the new standard. Of course, needs to be tested head-to-head to the other ones. And now we have been always waiting for the monoclonal antibody for myeloma. We've always been very jealous from the lymphoma colleagues that have been able to use rituximab. And the hybridoma technology was born in myeloma research, actually, because it was a fusion of a myeloma cell line with B cells from the mouse, which actually created the monoclonal antibodies for the first time. And it was a Nobel Prize for Kohler and Milstead for being able to do that. And the anti-CD20 was first used in '93 and approved in '97, and now it's a staple for the treatment in lymphoma. To integrate monoclonal antibodies to the current frontline therapy, we have to understand that we don't have a good grasp of the most important mode of action of these monoclonal antibodies, but particularly CD38 has multiple mode of actions, which are listed in this slide, talking about ADCC, ADCP, CDC, and the direct induction of myeloma cell apoptosis, which is very important when you integrate to alkylating agents or to immunomodulator therapy. So what's the data? The data for second line and more comes from this paper. We came in the New England Journal of Medicine. You guys all know it very well. It's a study in which it was randomly assigned patients with relapse and refractory multiple myeloma, not frontline, but relapse and refractory, were randomly assigned to receive Daratumumab, the anti-CD38 antibody, plus dexamethasone and lenalidomide, and compare with lenalidomide and dexamethasone, and the primary endpoint was PFS. The updated efficacy is such that when you combine the three drugs, you have an overall response rate of 93%, and this is in relapsed patients. So it's very reaching the same numbers as the induction regimens I was talking to you at the beginning. And very importantly, you had a profound CR rate of about 23% on those cases. As if you talk the CR rate and the SCR exceeds the findings in the induction regimens I just listed you, which is almost 50%. So here we have a regimen that could give that type of profound cytoreduction and gives an advantage in PFS to the control arm, which was Lendex. And the most important thing, and we're going to have a session talking about MRD negativity and the impact of that, but you can see here that people on Daratumumab and Lendex achieve a significant MRD negative state, again in the relapse setting. And this overall the progression-free survival on MRD negative is very important and easily achieved. And with this combination, you can achieve also very good responses and very profound advantages in PFS, even if you have high-risk cytogenetic. And the curves in overall survival appear to be separating now. In terms of toxicology, you see that this regimen is very well tolerated, and it is easily movable to the clinic. So if you can compare Pollux, this trial, with other trials in which they compare against the same Lendex, you can see a hazard ratio of 0.37, which is quite robust and compares very well. So if we can conclude on this combination of Dara, Lena, and Dex, there is a 63 reduction on the risk of progression or death in the combination, and doubles CR and SCR rates, and gives you MRD negative states. So I think we fulfill some of those criteria that we needed to call it as an induction regimen. But if your patient has renal insufficiency, or for one reason or the other you don't want to use the lenalidomide compound, you could choose bortezomib instead. And in this trial, 250 patients in one arm, in the other 247, randomized phase 3 trial, with the same principles. They also see an advantage for the addition of the monoclonal antibody to the bortezomib dexamethasone arm. And importantly, you can achieve MRD rates of also indicating robustness, again, in the relapse and refractory setting. The outcomes of patients who are MRD negative with the combination with Daratumumab can be achieved, and those patients have very long progression-free survival. And if this happens with one prior line, imagine what would happen if it's in the front line. Again, you can also see advantage in patients with high-risk cytogenetics, and the overall survival also appears to indicate an advantage for the triplet in combination with a monoclonal antibody with a hazard ratio of 0.63. So similar to the conclusions on the first combination, the use of Daratumumab plus bortezomib and dexamethasone will give you a higher CR rate and MRD negative states. The combination is well tolerated, and it can be moved in the front line as an induction regimen. The question is now, the last point is, can you mobilize stem cells? Because remember, many of the progenitors, not the major stem cells or the myeloid stem cell, but the progenitors are CD38 positive. So the question is whether you can actually mobilize. So there is no data still well systematized, but from this trial done in Europe, where they added Daratumumab to different induction regimens in the first line and in the relapse setting, many patients went on to collect stem cells. And here you have a list of patients that either were mobilized with cyclophosphamide or Plerixafor and GCSF, and they all had adequate collections. And the next question then is what happens post-transplant. I mean, one thing is to actually be able to collect. The other is to make sure that you could actually sustain the graft post-transplant. So what we did, we have done in preparing of this talk is look at our experience, and this is unpublished material. Just indicating 11 patients that received Daratumumab pre-harvest and post-harvest. The question that you ask when you do pre-harvest is if these patients had any disturbed collection. And when you do it post, to see whether they have any disturbed engraftment. And as you can see, there was no delays or no problems in the yield of stem cells obtained, and there was no problems in the engraftment. So in summary, you can see that it appears safe from data from the European group and also from our own data. So to finalize my argument in favor of combining monoclonal antibodies to IMiDs as a novel induction regimen, I would say we fulfill the reduction of the comorbidities associated with the disease. We achieve good disease control. We achieve a robust control and can be translated in progression-free survival and perhaps overall survival. It is well tolerated, and it looks that it will not interfere with the stem cell collection. I hope that I have answered the question for this debate, and I thank you for your attention.